You know, PBMs may be the best example of the adage that the government is always trying to fix its last solution. Let that sink in for just a minute. Dr. Frank, in your testimony, you said that, quote, retail pharmacies face an array of challenging economic conditions threatening the survival of some of those operating in rural America. Yet much of what threatens those enterprises is not tied to PBMs, end quote. And then you highlight a number of potential contributing factors in your testimony, but I would like to seek some clarity on your conclusions, as I am from Wyoming and I represent the least populated state in the nation and the 9th largest land-wise. So obviously we have a lot of rural areas in Wyoming that need to be served by pharmacies. And I want to discuss what the top contributing factors are. You even summarize your testimony by saying that, quote, there is little reason to believe that PBMs are the main economic force creating these risks, end quote. But in your opinion, what factors contribute the most to rural America's problems with access to pharmaceuticals?
I do think that, well, let me start by saying that the independent pharmacy issue is really different between rural areas and urban and metropolitan areas. And the point I was trying to make was this is a problem because pharmacy deserts are growing in this country, and about half of all rural areas are served primarily by independent pharmacies. So there's a problem here. I'm just not sure that the blame or the solution is PBMs. And to me, there are other things that can be done in policy that, you know, unfortunately it doesn't relate to antitrust necessarily, but are important fixes for keeping rural places healthy. And I think, you know, we do it in a variety of other parts of our public programs. We do it in Medicare for hospitals. We do it in just a whole variety of areas. And I think that there are lessons to be imported into...
Such as
making payment adjustments for rural pharmacies. So, for example, you add a bump to an independent rural pharmacy when they're like the sole community provider or something like that. And so I think there are policies like that that can preserve these things because even though they're at a potentially efficiency disadvantage, they, as a community's resource, they have an efficiency advantage in that they keep people healthy in important ways.
Right. I think that we only have a couple of Walgreens in the entire state of Wyoming. We have one Whole Foods in Jackson. You know, we don't have the access to some of these chains that other places have. Dr. Van Nuys, turning to you quickly, you provide a number of policy recommendations which include increasing transparency, reevaluating the rebate system, scrutinizing vertical integration, and better aligning PBM incentives with patient and payer interests. There have been efforts in recent years at the state level to make reforms to the PBM structure. Have any of these efforts been successful?
I know that the state legislation has been, some of it has been relatively recently passed and is only now being implemented. I have not seen the data that lets us evaluate how that is working. I do know that what they did in Ohio when they audited their PBM and fired them for that 31% spread pricing margin and hired a single PBM to administer their whole Medicaid managed care program, that has been saving them $150 to $200 million a year.
So there is one state that has successfully done some reform in this area.
And other states have done similar, I think.
Okay. Do you think that this is something that could be accomplished at the state level, or is it your conclusion that Congress needs to act as well?
I do think that some progress can be made at the state level. I do think because these are, you know, national organizations, it may be more efficient to have them subject to a single set of rules. I don't know.
So do you have any particular state that you would recommend that we look to what they have done to determine whether that is something that could be implemented on a national basis or that other states ought to be looking to for addressing this issue?
So most of the state legislation that I've seen is kind of piecemeal, right? They go after spread pricing or they go after registration or something like that. And so I don't think there is any state that has accomplished the big.
What about the rest of you? Do you have any examples of where there are states or areas that they have successfully addressed the PBM issue?
Well, I can speak to at least one situation that I studied that is probably more an example of what not to do, and that was the comparison of Michigan and Illinois, where Michigan thought that it could carve out specialty and specifically carve out those aforementioned curative therapies for Hep C, Sovaldi, and so forth, back in 2012. And what happened was that Illinois kept PBM model in place. The market evolved, the market changed. Sovaldi and other drugs went off patent, cheaper generics became available. The lack of a PBM in Michigan's context meant that they were not nimble enough to move towards the cheaper generics that became available and cheaper substitutes that were available from other manufacturers. And they wound up spending about $50 million more than they otherwise would have compared to Illinois.
Okay, thank you. I yield back.